In this session, we'll be highlighting the importance of the role of nursing in stroke. We're very fortunate to have nursing staff from a range of a range of areas who will address and talk about the role of nursing from a multifactional sort of point of view. In this session, we'll be joined by Kylie Tastula, who is the Clinical Nurse Consultant of Neurosciences at Royal Prince Alfred Hospital. Kylie will be discussing the role of nursing in the acute setting. And Kylie's presentation will then be followed by Elizabeth O'Brien. Elizabeth is the Stroke Nurse Practitioner from Royal North Shore. And I think Liz is probably one of the nurses who's been around stroke the longest, because she was actually part of setting up the Royal North Shore Hospital Stroke Unit in 1997. Our next speaker then will be Amanda Buzio. Amanda is the Stroke CNC and Stroke Coordinator from the COFS Clinical Network in the Mid-North Coast, our local health district. Amanda will be presenting on the role of the nurse in a rural setting, which is so important, as Ken has just pointed out in that last presentation. Our final speaker this morning's session will be Sandra Lever, who is a Rehabilitation Clinical Nurse Consultant at Graithwaite Rehabilitation Services. And Sandra will be highlighting the role of nurse in the rehab setting. And while this afternoon we'll be talking about the role of the team in rehab, it's really important that we really look at how important the nursing role is in all aspects of the treatment of stroke. So I'll now ask Kylie to come to the podium and present her speech.
Thank you, Michelle. Thank you for the invitation to talk this morning. And I think we sort of demonstrate how well we work as a team in stroke. I often have reached out to Liz when I'm transferring into my new role. Amanda and I talk regularly about our patients and different things. And Sandra's on a lot of the same networks that we're on. So I think that sort of demonstrates how well we all work together as a team. So I'm going to sort of talk about my role, and I will start by saying we do not do telestroke, so we do things in our own service, so we don't activate CANs at all. And my role has sort of changed dramatically over the last 12 years or so that I have been doing it, along with how much stroke has changed. And I think part of my role is clinical, and part of my role is looking at all that data, the Angels Awards and things that Ken talks about, and coordinating the whole team and the stroke service to make sure we actually provide evidence-based care and actually look at what the guidelines show. So, I can't see that. So, as I said, I sort of have that overarching review. I work with Rebecca from Concord quite regularly just to make sure that we do things across the area. In terms of teaching, I provide a lot of teaching. I teach stroke survivors a lot. I teach within our own service, and I teach at whatever sort of forum is required just to make sure that people do know how to recognise stroke and then what they need to do when they actually see people who are having a stroke. Teach a lot at the undergraduate courses for uni to make sure they're aware of what's going on and what changes are occurring, and as well just to make sure our junior doctors know the junior doctors work on the stroke team with me. So it's teaching them how to do those assessments and what sort of treatments we need to provide. I have a bit of a research role, so I work with Craig Anderson. So I sort of coordinate a lot of his trials that he does. I find the patients who are eligible and we randomise those patients and then follow them up in terms of a research way. And then I also do quality improvement, so looking at our daughter needle times, things like that. And I will say my daughter needle time is nowhere near 89 minutes. My goal is under 40 minutes, and my team have to explain if it's above a 40-minute daughter needle time. And we've sat around that for a long time now. And I do have some different clinical roles. As I said, I do sort of the hyperacute stuff in the emergency department, and I also have some clinics. I see all the reperfusion patients, so anyone who's received thrombolysis or clot retrieval. I follow them up 3 months after, whether they come from our hospital, whether they're transferred in from other areas. I also run some concussion clinics in some other areas. So for patients who are coming in having a stroke, as you guys would know, you would sort of call an ambulance and you would be identified as being FAST positive, so facial weakness, arm weakness or a speech disturbance, and that activates the first part of a stroke call. So if ambulance feels that you're having a stroke, they pre-notify you, they put it into the little matrix on an ambulance, and that directs you to the appropriate hospital. So if you fit that FAST positive, it's now out to 24 hours in Metro Sydney, so if you're within 24 hours of stroke onset, you're FAST positive, they direct you to a stroke capable hospital, so you don't have to go to a hospital that doesn't treat and then one that does treat. And that will be extended out to rural areas as well over the next couple of months. They will then pre-notify our stroke team, so we put out a hospital-wide page, and we're in the emergency department waiting for you when the ambulance arrives. They tend to give us bare minimum information. It sort of might be a 60-year-old male, fast positive, last well known at 9 a.m. So that's what we got before we came in. We then see them in emergency department. We assess the patient, so we quickly do a NEIS score to assess how severe that stroke is. We work out where the deficits are. We try and get IV access, so we have one person on one side of the bed who's assessing. We have one person on the other side of the bed who's getting in a cannula and taking bloods. We've got someone who's ordering the scan, and I tend to make sure all of that's happening. Either I'm doing the assessment, we're talking to families, we're trying to get more collateral history about the patient to find out what's actually going on. We tend to give about 3 minutes for all of this to happen, and then I tend to start tapping my watch to get people to move on, to get them into the CT scanner as quick as we can. So this is sort of an example of a stroke call that we actually had. So they got to triage at 6 minutes past 10 one morning. So they were last well known at 9 a.m. We had a definite onset from that. The families could tell us that they had been perfectly well, they were talking, and all of a sudden they collapsed. We did the NEIS story. We got some stroke-specific risk factors. We looked at bleeding risk in terms of thrombolysis, whether they would be eligible, they wouldn't be eligible. We look at their pre-morbid level of function. So sort of driving, banking, shopping is our rules. How independent was that patient and how eligible would they be for treatments after that? And then we have the IV access and the bloods. And then we're moving on to scan. So this is the NEIS score that we do. So it's sort of different 11-point scoring system that rates how severe a patient's stroke might be. And this particular person was scoring a NEIS of a 7, so it sort of puts them at the mild stroke. They had a bit of a facial droop. They had a left arm weakness and a left leg weakness and a bit of sensory loss down that side. Then, so 26 minutes past 10, so 20 minutes later, their scans are complete. We have all of the information through. We can see whether they're having a large vessel occlusion, as Dr. Butcher went through. We can see if they're having an ischemic stroke or a hemorrhagic stroke. And we can see that green area here for this patient is the area it's at risk for her. And so it's about 39 mils, so it's a reasonable size stroke. So the decision making, so that's sort of done between myself and the team. We work out whether the patient's eligible for reperfusion therapy or not. We talk to the patients and the families about their feelings about it, and then we make decisions from there. So this patient was given IV thrombolysis, so they were thrombolysed at 20 to 11. So about 31 minutes after they arrived. And I'll put a caveat that this patient had COVID, so it slows down our process a bit. So we actually have to then get them to different scanners, different areas and that sort of thing. But so they had no bleeding problems. They were within onset time and they had no other contraindications. So an hour later, I re-reviewed her, one of Professor Anderson's trials. We have to re-review them at the 2-hour mark to see if they're then eligible, and she had actually completely resolved. So her weakness had gone, her speech came back to normal, her facial droop had gone, and she was completely perfect. She was very, very excited by that point. She wasn't eligible for ECR. She didn't have a large vessel occlusion, but the next part of my role would then be coordinating the ECR team, so making sure the INR team is available, making sure anaesthetics are there, looking at whether they need ICU or they're going directly to the stroke unit, and coordinating that everyone around actually knows what's happening. And then everyone gets followed up at the 90-day mark. So I sort of hand over care to Mariam in the stroke unit, and she coordinates all of the inpatient care. And then on discharge, I tend to follow them up again. And at 90 days, I review everyone. If they've come from an external hospital, I make sure that they've got everything in place at that external hospital. They've got neurology follow-up, they've had cardiology, whatever might need be doing. I often then call Michelle and say, can you link in with this patient because they need some help, they need some services, if that hasn't already been done. And then our local ones, I make sure the same thing has been done for them. And then that helps us keep track of what our outcomes are actually like to make sure that we're doing what we should be doing. It also helps me get a bit of a story if patients had good experiences, bad experiences, what we need to improve on and what we can work on moving forward. So as I said, the ECR is sort of the biggest thing that's probably changed for us. Our patients come from everywhere. So our normal referral patterns are sort of Dubbo, Bathurst, Orange. We routinely take from there. So I spend a lot of time talking to medical retrievals and choppers, working out where they land. We've all got apps on our phone, so we literally follow them across the mountains to see what time they're going to land at RPA. We all go up there and we bring the patients down. So they go straight from level 11 to down to level 5 on our angiopad, and that's the time that they've got to assess the patient. So everything is done very quickly and coordinated to make sure nothing is delayed. As I said, so this one, 31 minutes, a bit slow, but our average door to needle time is 45 minutes, and that's 24 hours a day. And I guess I'm there to make sure these processes work. Our door to needle time was really bad at the beginning. We had a lot of meetings coordinating all of the different departments to work out what our processes were, where we needed to improve. And everyone actually now gets really excited about stroke. And even our emergency department, they're fabulous. They actually try and work with us. Back when we first started, I think it was a nice and cruisy job. I had about 100 stroke calls a year. Now I think we're up to about 1,000 stroke calls a year, and everyone knows sort of what to expect, and the nurses will come and dob on me if after hours the medical staff aren't doing things as quick, and they'll say, this doctor didn't do that, Kylie. They told us to get off the ambulance stretcher, and so then we can actually improve things. So it actually works quite well. So a few of the things we do look at is our door to needle times. We also need to look at times from the angio suite, so the time someone gets into the angio suite to the time we puncture a groin to start a procedure, and how long all of that takes. So we work with anaesthetics to try and improve those processes as well. And then PR. I think a large part of my job is playing PR, making sure all the departments get along. It's a huge, big team. It involves most departments across the hospital. There is a lot of ego involved a lot of the time, so it's making sure everyone gets heard, everyone gets listened to, we all speak to each other, and we all sort of resolve any of the issues that do come up and try and work out how we fix things and try and make sure everyone gets a voice. I know Ken mentioned we've got a lot of stroke specialists at RPA. We're extraordinarily lucky. Our executive are very on board with everything that we do, but I think a lot of it comes down to we've got data to prove everything. We sort of work with everyone, allied health, everyone are a huge part of our team, everyone gets a say, and we do tend to listen to what everyone has, and I think it shows in what we do for most of our patients. And that's kind of the biggest part, I guess. My part is giving a voice to you guys, making sure that we actually pay attention to the patient who's in the bed. Often when things are done so quickly, you tend to forget that there can be a patient there. So it's sort of that really important stopping, and the first thing out of your name should be, my name is Kylie, this is Alex with a stroke team, rather than can you tell me your name and your age, date of birth. So I think it's sort of making it a little bit more human, and as Ken said, it's a very anxiety-ridden time for a lot of patients, so it's making sure, even though it's not a lot of time, we do sort of stop and make sure that we do treat people with a lot more humanity and dignity than what I think sometimes can be in hospitals. And that's sort of my whirlwind trip of what I do. And I think part of my job, Liz is going to talk about in terms of the role of the NP and what that actually means for our stroke teams now moving forward.
How can I keep up with that? Cripes. No wonder her daughter needle is so low. Yeah. I could just see her sitting there tapping her foot. Okay, so my name's Liz. I'm the nurse practitioner at Royal North Shore Hospital, and as Michelle said, I've been around for a really long time. You and I both started in stroke about the same time, didn't we? Yeah. I've been at North Shore for a very long time. So I'm going to talk about the role of the nurse practitioner. So the role of the nurse practitioner is very new to everyone. But mind you, that title has been around worldwide for a very, very long time. In the UK and the USA, they've had nurse practitioners since around about the 70s. So we're a little bit slow catching up, but we're getting there. So I'm really lucky to work at Royal North Shore Hospital, and I took a couple of snaps of our new buildings. Well, not so new now, actually. We've been in there for 10 years almost. It was 2012, so yeah, this is our 10th year. So still nice to think that it's new. And some parts of the hospital you can actually see the Harbour Bridge, which I love. So it's very nice. I go for a walk on the Oval most days, so it's nice. So a nurse practitioner is a registered nurse. We're educated and authorised to function autonomously and collaboratively in an advanced and extended clinical role. So that means that nurse practitioners have a lot of experience. We know who to talk to, how to talk to them, and how to get things done, which Kylie just showed as well. So the NP role includes the assessment and management of patients using that extended nursing knowledge and the skills that we've built up over time. We can initiate diagnostic investigations, so we can order a chest X-ray, we can order a CT scan. In the public hospital, we can order an MRI brain. So all very important things for stroke. We can prescribe medications, so you don't have to see us in clinic or in the hospital and then go to the GP for your prescriptions. I can actually do that for you, which is very helpful because then I know you've got the script in your hand, and when you walk out of here you can stop at the chemist in the foyer and start taking your medications that day. You don't have to wait for a GP appointment. This is when you see me in clinic. We can make direct referrals to other healthcare professionals. So if I've got some issues, I can refer you to a physiotherapist. I can refer you in conjunction with our team of neurologists in our hospital. I can refer you to other specialist teams as well. So our nurse practitioner role is grounded in the nursing profession's values, knowledge, theories and practice. So that's all very high and upper level, but this is actually how we look at the patient, how we do a very broad systems approach to how we manage patients, whether they're in the ward, whether they're an outpatient, whether we're actually doing primary care. And our nurse practitioners work collaboratively, but we're an interdependent member. So we're independent, but we also rely on everyone else in the stroke teams to actually provide our care. But we're very autonomous in what we can do. So this is just a little bit of legal jargon. So a nurse practitioner is a registered nurse, and nurse practitioner is actually a protected title. So no one else can use the title of nurse practitioner unless they have been endorsed by the National Nursing and Midwifery Board of Australia. We have to be endorsed in accordance with the Health Practitioner Regulation National Law Act. And endorsement allows the nurse practitioner to initiate those diagnostic investigations, prescribe medications and make referrals. So we work at an advanced practice level. So we have lots of expert clinical knowledge, specialised education. Most nurse practitioners have a very specific field that they follow. We have complex decision-making skills, so we know that when someone presents, we can look at A, B, C, D and work out that E may be the answer. We also have quite high clinical reasoning and diagnostic skills. We have the ability to initiate and evaluate therapeutic management plans. But importantly, being an expert by experience in a specialty is not on its own sufficient for a nurse practitioner to be endorsed, nor is accepting the fact that the doctors might not want to do this task, or you've learnt how to do this medical procedure, and so therefore you're going to be a nurse practitioner just because you know how to do it. You have to know the wheres and whys and behind it. So there's a couple of different ways a nurse practitioner can be endorsed. So applicants must demonstrate evidence of successful completion of an accredited program, and the Nurses and Midwives Board must have approved that nurse practitioner program at a master's level. Pathway 2 is where applicants demonstrate evidence of a program of study at a master's level that is clinically relevant to how they're going to be working in the context of their advanced practice nursing. And they must also then do some supplementary education that demonstrates equivalence and meets national competency standards for the nurse practitioner. And so one of the major things is that someone can do a master's in advanced nursing, but they haven't done a pharmacology section of that master's. And so that's essential for being a nurse practitioner, is that you have to do a very intense pharmacology block within your learning. So someone can do a Masters of Advanced Practice, but then have to go and do some extra work on their pharmacology before they can actually be endorsed as a nurse practitioner. And we have to put together a great big folder full of all our background material to present to the board. So my career pathway took a long time. I was an RN and a clinical nurse specialist for quite a few years, even before I got to Royal North Shore Hospital. I'd been working in neurosciences, so that's neurology and neurosurgery, since 1987. Makes me sound really old. I had gone and done, after my initial general nurse training at Concord Hospital, Rebecca's hospital, I went back and did my bachelor's degree, and then I went on and did a graduate diploma of Neuroscience Nursing. I then did my Master of Nursing Nurse Practitioner in 2010. And I was endorsed as nurse practitioner in 2011. So I was the first stroke nurse practitioner in New South Wales. There was 1 or 2 nurse practitioners for stroke in Victoria, so we're a pretty rare breed. But now I think, Kylie, you're endorsed as a nurse practitioner now as well, which is really exciting. So I set up the stroke unit at Royal North Shore Hospital in 1997, so we've been going for quite a long time now. That took me into doing a clinical nurse consultant role, and we did an early stroke discharge program where we did some rehab for patients at home, discharged them early, and I followed them up there. But the love of my life at the moment is the TIA clinic that we run at Royal North Shore Hospital and have done since 2011. So since about 2014, I finally convinced everyone to give us a permanent position as a nurse practitioner in the TIA clinic. So that's my major role at the moment. So in the TIA and stroke clinic, so the TIA clinic is for those patients who present to ED with the symptoms that Ken mentioned earlier. And the suspicion is that they may be having a stroke, but these symptoms resolve fairly quickly. They have a CT scan and it all shows fairly normal. There's no bleeds, there's no artery blockages. But the concern is that these people are still having warning signs of stroke. So as long as they're all stable, resolved, and their secondary, their risk factors have started to be managed, they're discharged from the emergency department, and we see them in our TIA clinic within about 2 or 3 days of their presentation to emergency department, and which is also pretty rare. There's not a lot of TIA clinics out there, and there are some TIA clinics who are great and do a good job, but they actually don't see their patients for, after about a week or so. Within our TIA clinic, we can also provide them with an MRI scan and some cardiac investigations, and obviously a specialist review. So we do advanced assessment of these people who present with acute stroke and TIA. We look at their risk factors. We identify if they have hypertension, if they have high cholesterol levels. We also do ultrasounds within our clinic, looking at the neck vessels to see if there's any plaque or narrowing of the vessels, stopping the blood flow to the brain. Once we've established if they've had a stroke or not, we see them again straight away that same day after they've had their MRI. We can tell them if they've had a stroke or if we still think that this is just a warning sign of stroke, and we can start them on their medications to help lower their blood pressure, lower their cholesterol levels, give some diet and lifestyle advice about, making sure they exercise and eat well, because that's really, really important. We can give you as many medications as you could take in one go, but it's really important that you follow that up with good diet and good exercise and a really healthy lifestyle. So no smoking and not too much alcohol. I won't say no alcohol because that's no fun. Okay, so our TIA clinic runs twice a week. So we run it Tuesday and Friday mornings, and we're hoping to expand that to 3 times a week this year. Our patients are mainly referred by the Royal North Shore Hospital ED, but we also take patients from Ryde Hospital, Hornsby, if they've been transferred across for whatever reason, and Northern Beaches occasionally. But Northern Beaches now has a TIA clinic as well, but they don't have me. The patient must have had a normal CT brain and a CTA if it's indicated. Some patients actually these days don't get a CTA if their symptoms have resolved fairly quickly. They're not like, Ken specified that in his program everyone has to have a CTA, but not everyone does that. They have routine bloods just to check that their kidney function's okay. and then they're commenced on something like aspirin or anticoagulation if they have an irregular heart rhythm. So within our clinic is overseen by a neurologist, Professor Krause, who you will meet this afternoon when he comes along for his panel session, and he will be here, Michelle. Me and a registrar who is usually one of the advanced trainee neurology trainee doctors in our hospital. So we have a number of MRI slots and we have a number of cardiac investigations. So we see, doesn't sound like many patients, but when we do so much for them in a short spate of time, it does take nearly the whole morning to see at least 3 or 4 TIA patients and maybe 4 or 5 follow-up patients who we see from the stroke unit. So we see them, follow them up. So we can give them a management plan. We talk about the medications that we're giving them, stress the lifestyle and behaviour modifications, and then we can refer on to other specialist teams if needed, or rehabilitation for ongoing management and support. So some of the barriers to nurse practitioners in Australia is that we must work in a collaborative arrangement with a medical physician. Even though we're supposed to be independent, most nurse practitioners, especially in private practice as well, must also have a medical physician that they're working with. Nurses working in private practice are restricted by government funding and providing rights, so there are still only very small things that we can do. And nurses, MPs who work in the public system, we're also limited by providing rights. So we can only order specific tests or we have to use the medical provider numbers. And this is under review. So the benefits of the nurse practitioner is that it's full-time, dedicated to the TIA clinic. I teach junior staff on the ward and also in the clinic. It's a point of contact for patients, and it provides complete care from the ED to discharge and then follow-up. I provide support and education for patients, and it also enables the hospital to avoid admissions in low to moderate risk TIA patients. So these patients don't need to sit around in a hospital bed for days waiting for a number of tests that we can do in one morning, and they have an answer pretty well straight away. So just to finish up, there's a couple of other nurse practitioner roles in stroke in Australia. So the acute stroke nurse practitioners, of which Kylie is one of those, providing stroke unit management, ensuring evidence-based practice provided by all staff on the unit, first responders to stroke calls in ED and the wards, and early assessment and thrombolysis and ECR determination. A special nurse practitioner is the mobile stroke unit in Melbourne. The NPs are on board for early assessment of patients at home. The CT is done in the little truck outside their house. They're quickly assessed, given the thrombolysis in the truck outside their front door, and they've had a lot of success with that, and then able to transfer to the nearest centre for clot retrieval if needed. So that's me done. Thank you very much. I went a little bit over time. So I'll hand over to Amanda, who does a fantastic job up north.
Thank you. Thanks very much, thank you. I'm going to change pace a little bit and take you back to Telestroke. My role as a stroke clinical nurse consultant at Coffs Harbour Hospital and for the Coffs Clinical Network is very similar to the positions that Liz and Kylie have described. But what I'm going to do is really talk to you about how we got involved with the Telestroke project when it was still being designed and developed, and what impact that has had for us up at Coffs Harbour. So, just make sure I can work this. So I'm hoping that you're familiar with this slide. Ken's stolen my thunder a little bit with some of these statistics, but this slide is from the 2020 Stroke Foundation report on stroke in Australia, no postcode untouched. And what you can see there is that we know that as the population grows, so do the number of people having strokes, and we tend to think of stroke as a condition of ageing, but as Ken has mentioned, we have a quarter of people under the age of 54 when they have their stroke. You may be surprised to know that regional Australians are 17% more likely to have a stroke, or maybe you're not. than those living in metropolitan areas. And in particular, the north coast of New South Wales, where I come from, is considered Australia's hotspot for stroke, with more people having and living with stroke than anywhere else in Australia. So I thought I'd just spend a little bit of time explaining what our area is like. So the Mid-North Coast is a local health district that covers about 11,000 square kilometres, with an estimated 220,000 residents living within the district. But there's periods of time, as you would imagine, during tourist high seasons where that resident number surges to double that amount. The main health issues facing the people living in these areas are mental health illnesses and chronic age-related illnesses such as cardiac, pulmonary, diabetes, renal disease and dementia. Like many regional and rural areas, the Mid-North Coast also has significant groups of disadvantaged people, including Aboriginal people and refugees, people on low income, and people living in small, isolated communities quite distant from health services. All of these groups are at risk of poorer health outcomes and risk factors such as increasing weight and obesity, low levels of physical activity, poor diet, and the number of people who continue to smoke is quite high, with very little access to specialist services and often even just GP services. The district is broken up into two clinical networks, the southern half covering Port Macquarie, Kempsey and Wauchope and surrounds, and the northern half, where I work, covers the Coffs Harbour, Bellingen, Maxwell and Dorrigo areas and surrounds. And within that district, there are three main Aboriginal communities, the Gumbunya, the Dunghutti and the Biripi nations. And that's really important because people of Aboriginal and Torres Strait Islander heritage make up almost double the population, so 5.7% of the population in the district, which is almost double the population that is quoted for New South Wales in general. And Aboriginal and Torres Strait Islander people have higher rates of all known risk factors for stroke, have 3 times greater incidence of stroke, and are at greater risk of dying from stroke. And when we look at the rates of risk factors for stroke in our area, and the fact that regional Australia is made up of older Australians, it's perhaps not surprising that we have such a high incidence of cardiovascular disease and stroke, and as I mentioned before, but with very little access to specialist services to help manage those conditions. So what services do we have to support people having a stroke up in the Mid-North Coast area? Well, whilst the stroke service models differ a little across the district, both networks are fairly similar in terms of stroke and TIA case numbers and available resources. We have New South Wales ambulance bypass systems in place, as mentioned previously. So if the ambulance service attends to a patient who presents fast positive, so they're the symptoms that they look for, that alarms them that this is a person with a stroke, they will take them to the closest primary stroke centre. So that's either Port Macquarie Hospital or Coffs Harbour Hospital. The Port Macquarie Hospital also has a stroke unit, and that's overseen by a geriatrician. And at Coffs Harbour, we have a stroke unit that is overseen by a general physician who has a particular interest in neurological conditions, including stroke. Both sites have the involvement of their multidisciplinary team, and we've got access to advanced imaging and additional specialties relevant to stroke care, although some specialty cardiology and vascular procedures do require the patient to be transferred to a tertiary level facility like John Hunter. There's a stroke coordinator position in each network, and that's part of my role at Coffs, and we're responsible for ensuring that systems and processes align with current best practice. So the Coffs service also has the advantage of being co-located within the rehabilitation ward. And what that means for the patient journey is that they are very quickly seen by our allied health team, and that allied health team remains with them across their whole inpatient journey from acute stroke management through to rehab until discharge from the service. But like many regional sites, we do not have a stroke neurologist, as Ken has mentioned. They're like hen's teeth. So with over 1,000 stroke presentations in our district, we needed to explore creative ways of providing evidence-based care to those acute strokes who presented to our service. So Ken has explained what the current statewide service for Telestroke looks like, but I thought I'd spend a few minutes just talking about how it evolved and what my involvement in that was. So Telestroke really has evolved over a number of years, and it's been driven by a very small group of passionate clinicians beginning in the Hunter, New England area. In 2017, I was approached by one very enthusiastic neurologist with an Irish accent and the ACI Stroke Network to get COFs involved to test if the model that had been started in the Hunter, New England area could extend beyond health district boundaries. What you may not know is that each district in New South Wales operates as a separate business entity. So although we all claim to be part of New South Wales Health, we actually have quite distinct districts that we cover, and we have distinct particular business systems and processes that don't always cross districts or cross regions. And so that can pose some particular challenges for clinicians, particularly when we're trying to work across from one district, one health district, into another. And that little graph there just shows you, although it's hard to see with the script there at the bottom, but it just shows you that really this concept in New South Wales started way back in 2013. So I think we did pretty well to get it off the ground by 2020, because that's a very short period of time in terms of introducing a major new health service. So I've got this little video here that I'm going to show you. Now, I'm not sure how I get that started. Do I just press?
Ron's a 64-year-old chap who's woken this morning around 8 a.m. with some left-sided weakness, also some slurred speech.
Hi Ron, my name's Emma. I'm one of the nurses. I'm just going to have a little look at you. Can you smile for me? Really big smile. Good job. Okay. Can you squeeze my hands tight as you can?
I think it is extremely important that when stroke patients present anywhere in New South Wales, they have access to the best quality of care that is available.
I'm concerned that your symptoms are suggestive of having a stroke today. What I'd like to do is refer you to the Telestroke service and also initiate a CT scan for you.
Telestroke is a new model of care which allows stroke specialists like myself access to patients presenting to rural and remote areas. We have full access to patient imaging. It also allows us to look at their imaging as it is being processed.
So the diagnosis is obviously correct. He is having a stroke, and we can see that it's a fairly large stroke.
Telestroke is important to a regional hospital like Coffs Harbour because it provides equity of access to specialist care for our patients.
Coffs Harbour Hospital is one of our rural and regional hospitals which has had a huge investment in both core networking, HWAM, and wireless infrastructure over the last 2 to 3 years, which means doctors in metropolitan hospitals can now provide services to Coffs Harbour Hospital using telehealth.
It allows us to provide hyperacute stroke care to all patients.
The same services that we can provide in well-serviced city hospitals, it is exceptionally quick and very, very easy for us to use. You can see the patient and you can interact with the patient, you can examine the patient.
Which allows us to assess the patient as if we were actually there.
The important thing is that we've got a treatment for this sort of stroke, and it's a really strong blood thinner to try and break up the blockage which is causing the stroke.
Our clinicians get the benefit of interacting, collaborating with those specialist clinicians that are based elsewhere. That builds their skills, their knowledge base, and also their confidence in the treatment of stroke.
The Telestroke pilot has proved to us that we're able to reliably provide telemedicine services using the Skype for Business platform. And this proves that we could use this technology for many other specialties anywhere across the state.
The point of Telestroke is that we identify patients early who are amenable to treatment. This absolutely will improve the outcome for patients with a stroke from being completely dependent on carers at home to being somebody who is relatively independent and potentially being able to get back to work. This is life-changing.
I felt a gurgling in my neck, and then everything went all fuzzy. Ambulance arrived and took me into Coffs Harbour Base Hospital. All symptoms shone towards a stroke. Once they determined that, I was straight on Telestroke to the specialist. I've returned back to work, doing the same job that I was doing prior to having the stroke. I'm back surfing again. To be able to paddle out and sit on a board and just think all the thoughts away, leave them in the ocean, it's just the best therapy ever. Yeah. I owe my speedy recovery to Telestroke and what happened that day, because specialist help was at hand so close, so quickly. I wouldn't like to think what it was like before that treatment was available.
That video really illustrates what this service is all about, and it was used to help influence, I guess, the bureaucrats who make the decisions regarding what services will be implemented as to the benefits of that service. So with the commencement of the statewide service, Coffs underwent a comprehensive change management process, as Coffs and Port Macquarie were the test sites, or the pilot sites for demonstrating the effectiveness of Telestroke. We were the first sites to go live with the New South Wales Telestroke service in March in 2020. I was appointed into a 12-month project implementation position, and as a result of our participation in the service, my substantive position was increased from a part-time to a full-time position to ensure some ongoing local support. The Director of Nursing was our executive sponsor, and we convened a steering committee and working group to guide and implement the changes. And the project implementation period was well supported by the Ministry of Health, by the Agency for Clinical Innovation Stroke Network, and post-implementation at Coffs continues to be greatly supported by the Telestroke clinical team. So over the course of the 12 months, we held meetings, we installed updated imaging software, we developed protocols and clinical pathways, we implemented education programs, we celebrated successes with newsletters and media releases, we ensured alternate processes were in place if the tech failed, we worked through how to implement the process within the hospital, and we ensured that Telestroke was embedded in the Coffs network as standard practice. We worked closely with the ACI project team to problem solve challenges, and we helped develop some of the resources for subsequent Telestroke sites. And I really think it's worth acknowledging that introducing a new system like this involves many different departments across the facility and outside of the facility, including the ambulance service, our emergency department, our pharmacy, our imaging, our IT, our ICU, and our stroke unit. So it's quite a complex process to implement. But what has all the work achieved for Coffs? Well, the easiest way to illustrate this is to compare our treatment times pre and post statewide service implementation. Everyone's focusing on this concept of door-to-needle time, and the reason for that is we know that we have a window of time to give treatment for ischemic stroke, but the faster you give it, the better the outcome for the patient. So there's not a little bit of competition between stroke services, and we all think of Kylie at her 40-minute mark, very difficult to achieve. But in early 2017, when I joined the service, we weren't really offering reperfusion treatments. There'd been a break in some of the positions that were located at the hospital, and so some of these treatments had dropped off, and we hadn't ever really offered clot retrieval because of our distance from a clot retrieval site. But when we joined the pilot, we started offering thrombolysis, and in fact, Nick in the video was the first chap that we thrombolysed. He was 34 when he came in with his stroke. And you can see he had a remarkable recovery. But look at those terrible door-to-treatment times of 104, 118 and 103 minutes. Formalising our systems and processes and putting in place some additional resources to support this implementation has resulted in a significant improvement in our treatment times for thrombolysis, and this has been consistently maintained after project implementation. To the extent that we've now achieved gold status, as Ken mentioned, in the World Stroke Organisation Angels Awards, meaning more of our stroke patients have a better chance of a good recovery. Telestroke provides expertise in acute stroke management in the absence of a local expert, and it's resulted in improved acute stroke care at costs. And I think it's worthwhile saying that this project has been one of the most rewarding and successful change management processes that I've been involved in health, and I'd like to acknowledge that it's only been made possible by the collaborative efforts of these health partners. Thank you.
I'm so glad I'm not competing with them for needle times. I don't have to worry about that. So I'm going to talk to you now about the role of rehabilitation nursing in stroke. And I'll just make sure I've got this right. You'll see I'm clinical nurse consultant in rehabilitation, and I'm based at the lovely Braithwaite Rehabilitation Centre, which is at Ryde Hospital, and you'll see some lovely photos of that up on the screen. So for this session, what I'm going to do, that's a lovely gym area, isn't it? At the top left-hand corner. So for this session, what I'm going to do is just talk to you about what rehabilitation is and what rehabilitation isn't. I'm going to talk about what rehabilitation nursing is and just some of those roles and functions of the rehabilitation nurse. And then if I've got time, I'll do a quick case study, but I'll see how I've got time. I might be actually flying through that because I know we're running a bit behind schedule. So there's many definitions of rehabilitation, and we've got international definitions, we've got national definitions, we've got state definitions, but this definition is from the National Stroke Management Guidelines. And what it actually says is that rehabilitation is a holistic process that should begin the first day after stroke with the aim of maximising the participation of the person with stroke in the community. So to achieve this, we tailor the interventions that focus on impairments, activity and participation levels. Therefore, rehabilitation is a process that can occur in a variety of settings. So it happens in acute care settings, it happens in rehabilitation settings where I work, it happens in home-based services, it happens in outpatient services. So it happens in many different settings. But and as it says, it's included in specialist services as well. The point about this definition is to remember that rehabilitation is something that happens everywhere. So while we think of rehabilitation happening within a rehabilitation service, for stroke especially, rehabilitation should be happening in all those different settings. So as a nurse, we always talk about nurses carrying rehabilitation as part of their toolkit. So all my colleagues here are also providing rehabilitation care. The other thing about this definition is just to give you some of this language in case you don't understand it. An impairment is something that happens at the body level. So you might have a sensory impairment, for example. An activity is a task that you execute. So that's things like showering and dressing and eating and transferring and grooming. And participation is about being able to engage in life activities, so life situations. So that might be like going to a restaurant or going to work or going to a wedding, all those lovely things that we participate in. So they're the things that rehabilitation focus on. Particularly we're focused on activities and about that participation in life situations. So rehabilitation is fundamentally about a person regaining control over their body and their life. And for some people, as you probably all know, this entails their holistic reconstruction of the self. So when you've had a stroke, one of the major things that happens, there can be major changes, and part of that rehabilitation process is about facilitating a stroke survivor to reconstruct the person who they are. So that's about helping you to get to know the person now that you are since you've had the stroke. And that can take quite a long time, as you probably all know. It very much aims to improve the stroke survivor's quality of life, but it does require active participation. So it doesn't matter what we all do, if as a stroke survivor you're not participating in your rehabilitation program, we're not going to get maximum outcomes. So that's really important. So it is important to engage the stroke survivor as early as their condition allows that. As far as for rehabilitation nursing, so we're just going to focus on rehab nursing now. It's really important to know that rehabilitation nursing does contribute to the optimum outcomes for stroke survivors. These outcomes are maximised when rehabilitation nursing care is aligned with the care and the interventions provided by the multidisciplinary team and the goals and capacities of the stroke survivors requiring rehabilitation. So if the whole team and nursing is not working together towards your goals, then we're not going to get the best outcomes for you. So rehabilitation, as I said, is provided throughout the entire episode of a stroke survivor's healthcare, and all nurses, including my acute care colleagues here, should be adequately prepared to deliver rehabilitative nursing care. So rehabilitation is also practiced as a nursing specialty. So like myself, I'm a clinical nurse consultant in rehabilitation. I'm not a clinical nurse consultant in stroke. So my area of specialty is rehabilitation. I work in an inpatient service, but we also have rehabilitation specialist nurses working in a variety of different settings. In the UK, it's not unusual to have rehabilitation nurses also working with expert rehabilitation nursing knowledge and skills working in their stroke services as well. Very much rehabilitation nursing differs in its focus from many other nursing specialties. So we're very much, most nursing specialties are person-centred these days, but our approach is very much different. So the roles and functions of rehabilitation nursing is informed by what we call the competency standards. So that's that pink book up there. And it's also informed by the principles of rehabilitation care, which is a document that has been put out by the Agency for Clinical Innovation Rehabilitation Network. And I'm just going to briefly take you through some of these things so you really have an understanding of rehabilitation nursing's roles and functions. So with the competency standards, we have 7 domains of practice that informs what it is that we do. And these 7 domains include the rehabilitative approach. So that rehabilitative approach is very much the way in which nursing performs their duties. It's about knowing when to have our hands on and our hands off, which can be really difficult for nurses because nurses are taught that caring, and also patients have expectations that caring is about having our hands on and doing things for our patients. So it's very much a balance, and as you can imagine, it takes a lot longer to have your hands off and to be able to facilitate a patient's recovery and getting them to do things for themselves than it is to have the hands on and do it for them. But that's very much the rehabilitative approach. It's also about helping the person to be able to see possibilities and focusing on their abilities and not their disabilities. And it's also about getting to know the person who has had a stroke, what their life entails, what's important to them, so that we can then establish goals and work together. So we very much are working in a therapeutic relationship that is a partnership with the person that's had a stroke. We also have a teaching and coaching role, so very much we try and make every interaction we have with the person a teaching and learning opportunity. So this might be something as small about teaching you medication. So on a medication round, we might have taught you that the blue tablet is for, I'm not going to say Viagra. I'm going to say the little blue tablet, AF. So we might say, what's the blue tablet for? So we might have told you that the blue tablet is for AF, and then we might then, then asking you for that feedback next time we do medications, and we might add on to that each time. It might be doing things like teaching you to transfer safely. It might be just rolling in bed to start off with, then sitting up on the end of the bed, then to stand, and then to be able to turn and to sit into a chair. So all those interactions should be a teaching and learning opportunity. Our nursing interventions are informed by what we call observation, assessment and interpretation. So we're always observing what's going on, we're assessing that information, and then we're interpreting it to then inform what we'll do next. So it may be that, you know, I'm encouraging you to roll in bed for when you first come in to have rehabilitation, and you might be finding that really, really difficult, and I might be watching and standing back, and then I might think, well, no, this is actually going to make you really, really frustrated, so I might break that task down even littler and say, well, why don't you just reach out your arm over this way, and that'll take your top body over a little bit more. But it may be that I say, okay, like this is really too difficult at this point of time, so I'm going to help you by doing this. So that's all that's going on all the time, and it's informing how much hands we have on, how much hands we have off, whether this is your goal, whether it's not your goal, and whether I should be focusing on that. We also administer and monitor therapeutic interventions. So some of those interventions are independently nursing, and a lot of those interventions are done in conjunction with a multidisciplinary team. So that team working together is really important. Otherwise, we'll be working separately to each other, and also part of that team involves you and what your goals are about too. So that's all about communication and your transfers and your mobility and how we're showering, how you're grooming, what you can do, what you can't do, what we're trying to achieve. Management of rapidly changing situations are all those situations that happen in hospital that changes your plans for the day and sets all our nurses running all over the place. So it might be that you've had an episode of postural hypotension in the gym, or it might be that your blood sugar level's high, or you might have tried to get up and go to the bathroom by yourself without calling for assistance and you've had a fall. So they're all those rapidly changing situations. And then we have that coordination role. So especially in rehabilitation, there's so many team members, and that coordination is really, really important. And then ensuring quality of healthcare practices. So they're all the quality improvement activities we do. And it doesn't matter whether you're a rehab nurse or whether you're an acute care nurse or a nurse practitioner, everyone's having to participate in quality healthcare activities. So that just gives you a bit of a breakdown of what those 7 domains of practice are for rehabilitation nursing. These are just one aspect of the document in the Principles of Rehabilitation Care from the ACI document, and we call these the enablers of optimal rehabilitation. I think the very important thing about this one is that we've got goal-directed synergistic teamwork, and that's really important that we're all working together towards the goals of stroke survivors, and that we're not working separately from each other, because we're not going to maximise the outcomes if we're not working all together. But it's also about enabling self-management and providing a facilitatory environment. So if you need to transfer out of bed on a particular side, or you need to be in a particular bathroom where the rail's on one side, then we'll try and facilitate the environment so that we can maximise those outcomes. This is just quickly to show you some of the barriers to stroke, to nursing's contribution to stroke rehabilitation care, just so that you have an understanding of some of the factors that impact on this. And one of those important factors are that not many people understand the importance of nursing's rehabilitative role. And very much there's this belief that rehabilitation is about therapy performed by our allied health colleagues, which is also very important, but also the therapy provided by rehabilitation nurses is also really important too, and contributes to optimum outcomes. Also, that patient complexity, though, has an impact on the rehabilitation nurse's role too, because we have a duty of care to ensure that our patients are medically safe as well. So when we've got lots of things going on medically with a patient, then that will always be our priority over being able to provide rehabilitative care. And within rehabilitation services, our nursing hours per patient day are much lower than they are in our acute care services, despite that we need to stand back and encourage people to do things for themselves. So if you're in a rehabilitation service and you're not getting everything that you should be getting by a rehabilitation nurse. This is some of the reasons why, and these are some of the things that we need to be tackling. Patient-centred goal setting can also be quite difficult too. A lot of people don't know how to set goals, so they need a lot of support to be able to set goals. But there's also things like pain and fatigue and that also impact on being able to provide rehabilitative care. So in regards to Jack, quickly, okay, so I'll just introduce you to Jack. Jack's had a stroke. He has a history of diabetes. He's also had an amputation of his toe because of this peripheral vascular disease from his diabetes. He lives alone in 5 Dock. He loves gardening. He loves going to the pub on Thursday evenings with his mates. And he's also recently entered an intimate relationship with a woman that he's met at the club too, and that's quite a new relationship. So these are just to give you an idea of how it works. So these are Jack's long-term goals. He wants to return to live in his place with the need of support from his daughter Sue. He wants to be able to do gardening. He wants to be able to go to the pub on Thursday evening, which is very important. He wants to maintain his intimate relationship with Joanne, which is very, very important. And also to reduce the risk of another stroke and to prevent further amputation of his toes. So they're his long-term goals. So what we will do in our services when we're providing rehabilitative care is break those long-term goals down into short-term goals. And the reason why we do that is so that you can see improvements as you're travelling along that rehabilitation journey, and also that you're encouraged and motivated to work to those long-term goals, to achieve those long-term goals. And that's how we facilitate functional recovery. So these are just some of Jack's goals. So, he wants to be able to do gardening, and that means using small tools. And he wants to be able to go to the club to have dinner with his mates on Thursdays. So something like being able to use an adaptive knife and fork to eat his meals is working towards that goal. To be able to purchase a meal online with minimal assistance of one person. So is another short-term goal that we will have with him. To be able to dig a small hole. So we have a little garden outside, and to be able to dig a small hole and practice that and put in a little seedling is something that he can be practicing to work towards his main goal of a long-term goal of gardening. So that's just to give you some idea of how we break those goals down. So these are just some of the goals Jack would have had within the first week to 4 weeks of his rehabilitation program. They would have happened within the inpatient service as well as the outpatient service, and they would have had a timeline attached to them to make them measurable and achievable. These are just some of the functions that nurses would have done to help Jack with achieving those goals. So it may have been getting Jack to practice his speech exercises when we're talking to him, so that he can then order a meal at the club. It may have been able to get him to practice taking his medications out of his packets, so we would hand the medication to him and we would get him to practice getting that medication out of the packet. So he's using both his hands. It might even be something like, when he's in the shower, we might get him to be using his weak arm to try and reach out and get the toothbrush and start practicing to brush his teeth with the toothbrush. There's also things that we do to conserve function as well. So we might be doing things like to prevent shoulder subluxation, to prevent DVTs, also preventing falls. So there's lots of things that we're working on to prevent things from happening and to conserve function as well, which is a large nursing role. And then there's the evaluation role, and that evaluation role really takes that form of goal achievement. So those goals are really important, so we can measure how well functional recovery is going, and also to be able so that you continue to be motivated to continue your rehabilitation journey. And that's it. Thank you very much.
I might ask Lani to bring the microphone up. Thank you, so we can take a few questions. It's amazing, isn't it, the complexity of stroke? And it's also amazing how all of these people work so brilliantly together. And while we often just see the nurse as that person beside the bedside, and that is an incredibly important role because they provide care and they provide support, not only to the person who's had the stroke, but particularly to the carer. And they're part of that whole teaching role as well. But isn't it wonderful to see the sorts of things that our really experienced nurses are now getting involved with and being recognised within the medical field as for the important role they play. So we're going to take a couple of questions about any one of the things that we've heard about today. I've got Christine here in the middle, and Christine's from our Northern Rivers group.
I've got 3 questions.
You're only getting one, young lady, so make a choice of one.
Okay. How many other hospitals have NPs?
So, what box of questions?
How many other hospitals have NPs?
So there's only 3 nurse practitioners in New South Wales who specialise in stroke. So myself, Kylie and Alana at Prince of Wales. In Victoria, they've probably got a few more, I think 6 or 7, and a few more in a training program. Victoria put a lot of money into upskilling stroke nurse practitioners, so they actually have quite a bigger impact in that. So we have a way to go. There's nurse practitioners for other specialties as well. You'll probably find at least one in most hospitals. A lot of nurse practitioners work privately in their own clinics. A lot of mental health nurse practitioners. There are nurse practitioners in the emergency departments now who will also look after things like broken limbs and bits and pieces that are quite painful to manage. It's not working. Oh, I'm not going to say that all again.
I hope everybody online heard that as well. That's what I'm hoping. Do we have an online question at all?
So this question's for Kylie from Jenny. Regarding the patient who had a stroke and also had COVID, is there shown to be an increased chance of stroke when a person has had COVID?
So there is some. Can you hear that?
No.
So there is. No.
I might bring that up.
Can you hear me now?
We are really being led down by technology today, are we not?
Can you hear me now? Yep. Okay, so there is some links between COVID. So there has been some studies that show there's links between large vessel occlusions and having COVID. But I mean, over the 2 years, I think we've seen maybe 1 or 2 patients so we can contribute to COVID to the actual stroke. But there is links between, there is in New York and the Middle East, they definitely produce some papers showing the links between them, but we haven't seen a lot.
Because they've had far more numbers of COVID than we have. It's much more prevalent overseas. Because COVID can cause a clotting problem, which then would cause a stroke. So, and the strokes that people are presenting with are actually more severe if they've had COVID. But again, as Kylie said, we haven't seen a lot of that here in Australia. Our numbers have been relatively low, whereas UK, the USA, huge numbers of COVID, hence quite severe stroke. So we're actually very, very lucky here in Australia, and that we've had access to vaccines for quite a long time now. So make sure you get vaccinated. That's my COVID.
Do we have any other questions at all from the floor? Melissa's over here. Sorry, were you with somebody who wanted to?
Hi. It works, yes. Yeah. My question to you is, as I see you as a team, I see you as you from all walks of life, and north, south, east and west, and really well integrated, and I say, well done you.
Thank you.
I question outside of your capacity in the New South Wales health arena, how many, or if there is any other equivalent, unified, considered team that's put together that covers all the private health. And I say that because I am a nurse, I've had a stroke, I've seen it with uniform and outside of uniform. And I was an ED nurse, can't be anymore. And I'm just wondering whether or not there is a dialogue, there's other arenas, other agendas, other information base that is not tapped into. And because maybe it's locked into some of the private hospitals are still in paper-based.
Did either of you want to answer that, or are you happy for me to have a go at it? Oh, you got to love them. You got to love them. Yeah, I guess one of the things that I'd like to say is one of the things that has been achieved in stroke over the last 20 years, or certainly since Liz and I started, is that interrelationship that's happened between hospitals and across local health districts as well with stroke. The Agency for Clinical Innovation, both the Rehab Network and the Stroke Network, has been particularly important in doing that. And certainly within our public hospitals have provided an excellent opportunity for training, for interaction between hospitals within a local health district and also across local health district. One of the things that I think nurses have done more than anybody else is really break down those silos, and that there's not much ego in nursing, is my observation. I could be wrong, but there's not much ego in nursing. So they're much more prepared to share, to work together, to educate each other, to support each other. And I think that's worked excessively well in the public system. Getting onto your aspect about the private system, the private system is not, I believe, and this is a personal opinion, geared to deal very well with acute stroke. That anybody who has an acute stroke in this state really needs to go to their local hospital and be treated there, because then you have access to the quality of people that you have up here on the field. There is an exception to that in terms of the SAN, but that's the only acute hospital. But then you move into the rehab sphere, and the rehab sphere is a whole different ballgame as well. But we'll be learning a little bit about that this afternoon. But there's a lot more rehabilitation processes available in the private system than there is in the public system. However, again, the rehab network with the ACI covers that sphere as well. They don't only deal and work with people from the public system, they also deal with people who are part of the private system. So that interaction across and between facilities is occurring, maybe not as well as we'd hope, but it's certainly happening. And the other thing it's happening is that mentoring. You know, I guess Sandra's a case in point, that she's always available to do these sort of things, and she's been on the ACI Stroke Network for some time. And that interrelationship where nurses share information and get information out is really important. And this afternoon, I guess we'll learn a little bit more about how rehab as a whole works with that. But I particularly think nurses have done a great job of breaking down the silos across local health district boundaries and mentoring each other. And I'm happy to hand it over to the panel for anybody to add to that.
Thanks, Michelle. Can you hear on this microphone? Yep. So the only...
Liz, come on, Pete, love. You're not going to be heard down there, I don't think. Sorry, love.
So the only thing I was going to add to that is when it comes to our stroke nurses, we've actually got an Australian Stroke Nurse Education Network. It's the Acute Stroke Nurses Education Network, but it comprises everyone from primary care through to rehabilitation. So we're all members of ASNEN, and with ASNEN we actually provide free webinars that can be tapped into by community as well, by stroke survivors. ASNEN.org. You can join, it's free membership, and through that focus, we can actually provide collaboration between all stroke nurses Australia-wide. We have some New Zealand members as well. So if you are interested, you can actually just go onto the website, join and be a member, and you can log in and partake and keep fulfilling your nursing by tapping into what we do on asnen.org. ASNEN, ASNEN.org, O-R-G.
I'll just take one more question, because I think we might any more. Leslie Watkins is just here.
I've found that people that have stroke these days, they're not as debilitated as they used to be 20 years ago. I've experienced that. Now, the one thing that seems to be not clearing up is fatigue. The person will come out from the stroke, they expect to go back to work because everything physically is functioning, but they get to work and within a couple of minutes they're, oh God, I've got to get home.
Yeah.
And is that being addressed in your research and stuff?
Yeah. Do you want to talk about that? Because I can talk about, there is actually a study that's enrolling people 3 months after stroke, which is looking at fatigue and actually, a medication that can be used for fatigue. But fatigue is very common after stroke. We see it all the time, and it varies person to person. Not one fix fits all. And it does get overlooked. There's lots of other research studies as well about rehabilitation, I think, that Sandra could probably mention.
I mean, I was also going to say it's really important, and probably it's something you can pose at the question to the multidisciplinary team this afternoon when they do the panel around rehabilitation. But the important thing is with returning to work is that you also have that support when you're returning to work. So for some people, rehabilitation is a very, very long journey, and it's about the linkages into the correct services, whether that's through an ambulatory program or a home-based program or some other service that's linked in with your employers. So you stepped back into work at small steps rather than going full ball back into work, because fatigue will have a big impact on that. I mean, and even if you don't have fatigue, like being discharged from hospital or a rehabilitation program where you've had a huge amount of supports and then jumping straight back into it, you're going to get fatigued anyway, because, there's so much going on, it's bombarding, and so it is about your goals and breaking your goals to return to work, but there's shorter goals that leads into that returning to work.
Thank you. And I think there's a lot of smaller studies being done as well. I know that RPA is looking at following up with some of their patients post-stroke, looking at return to work and fatigue. So that might bring us to the end of this morning's sessions. Can I get you to ask any questions of the panel at lunchtime, because they will be there with us then? I would particularly like to thank each and every one of them for joining with us today. It's a really difficult time for health professionals to find their way out of the health system with COVID being at its rampant. So I'd particularly like to pay tribute to them all and to thank them very much for an excellent presentation. So would you mind joining me in thanking Kylie, Amanda, Sandra and Liz?